this will not be a technically oriented talk. It will be much more clinical for most people in the audience. And what I'd like to point out is that atrial fibrillation is common and seems familiar, yet there are ongoing developments in our understanding and treatment that can and will affect our management in the coming decade. In the next hour, I'd like to highlight some of the developments and trends in this evolution. Here's my disclosure slide. So it seems to us that stroke prevention and atrial fibrillation is simple. You ask the patient, or you determine, do you have atrial fibrillation? Then you assess the stroke and bleeding risk, and then you treat with an anticoagulant. What could be simpler? In the next hour, I'm going to explain some of the problems that we have now, and some of the solutions that are developing, and some of the things we can expect in the coming decade. The biggest problem is that greater than 50% of the patients at risk are not treated. So let's start with a brief history of atrial fibrillation. It was first described over 1696 BC as an irregular pulse. The so-called Yellow Emperor in China said when the pulse is irregular and tremulous and the beats occur at intervals, then the impulse of life fades. After that, there's a very long gap in the historical record. The next big part of the development in atrial fibrillation was in 1628, when fibrillation of the auricles was described by William Harvey in animals. Then there was a big gap until 1827, when the irregular pulse associated with mitral stenosis was described by Robert Adams. In 1863, we had pulse tracings by Etienne Maret. And in 1908, we had the first ECG of atrial fibrillation by Herring and Lewis. In 1963, Bernard Lown performed the first cardioversion. So what about stroke and atrial fibrillation and anticoagulation? A brief history of that. In 1930, mitral stenosis and atrial fibrillation were identified in autopsy specimens as auricular thrombosis. In 1991, a long time later, based on Framingham data, then the stroke risk of so-called non-rheumatic atrial fibrillation was identified and as a major problem. Then in 1996, I was actually surprised how late this was. Then finally, the AHA-ACCA guidelines recommended anticoagulation for so-called non-valvular atrial fibrillation as opposed to atrial fibrillation associated with mitral stenosis. So what about anticoagulation? The history of anticoagulation starts with dead cows in the 1920s. There was an epidemic in the middle of the United States of dying cows, and it was discovered that this was due to them eating moldy sweet clover. The problem with the sweet clover was identified and led to the discovery in 1940 of dicumarol, which was the element in sweet clover which is causing them to have bleeding. It was isolated and synthesized. Then in 1948, a stronger version of a similar chemical called warfarin was synthesized. By the way, a fun fact, warfarin comes from WARF, is for the Wisconsin Alumni Research Foundation, which funded the research. Then this was later, it was initially used as rat poison, but then it was discovered that it could be used for humans. And then we had trouble with monitoring it. And the INR was developed in 1983 for better monitoring of warfarin. And then in 2010, the first direct oral anticoagulant was approved. So let's go back to the steps in stroke prevention for atrial fibrillation. We have these 3 steps that seem so simple. Let's start with looking at the portion of treating with an anticoagulation, with an anticoagulant. Well, how good was coverage with warfarin? This was a study that was done presented in 2010, which was over 170,000 patients from the US MarketScan database from 2003 to 2007 with atrial fibrillation and flutter, mostly atrial fibrillation. They were assessed by the CHA DS score, and 42% of patients with a CHA DS of 3 to 6, which is high risk, were treated. In other words, 58% were untreated. Of those, only 30% received uninterrupted therapy for the first 6 months. So even of those who were treated, then they were interrupted therapy. So if we look at this slide, on the bottom and on the x-axis, we have the CHA DS score. So this is high risk, 3 to 6. And then we have the percentage of patients who were treated, and the hatched portion is very depressing. Those are the ones who were treated in an uninterrupted fashion. So how good was treatment in the warfarin area? Otherwise, if we look by in other studies. So this was a meta-analysis, and in this meta-analysis, they only found 9 studies which actually looked at treatment, which was classified based on the CHA DS score. And only 2 out of those 9 had treatment that was better than 70%. They ranged from a low of 39% to 92% on high-risk patients. Before we feel too good about that, the 92% was in Switzerland. It was not none of the studies in the US were that good. The treatment tended to be better at the high CHA DS scores, reaching 41%, not, if we can say reaching 41% to 100% in Switzerland, for those that had a CHA DS VASc of 2, greater than 4. This slide, the illustration is a little bit complicated, but these are each group of bars is one study, and they are ranked by the CHA DS score, where the first column being the total study, showing the total number of patients, and the part that is gray is how many were actually treated. And the study from Switzerland shows the highest treatment rate. But in general, there's a trend towards more treatment with higher CHA DS, but it's not very encouraging. So maybe it was better for really high-risk patients. What about the people who had a previous embolic stroke? Maybe people were really doing well with those, but not the other patients. Well, that actually wasn't true either. There was a meta-analysis of 54 of 98 studies, limited to those with stratification by risk, and publication date was for data from 1997 to 2008. And there were variable methods of assessment of risk. 29 studies were about patients who had an embolic stroke already. So this is the highest risk population. So we're starting out with 98 studies. Now we're looking at 29 studies that were just about patients with embolic stroke already. Highest risk population. 24 out of 29 had treatment levels of less than 70%. 21 out of 29 had treatment levels of less than 60%. And this is the summary of all those different those studies. They are ranked in reverse chronological order. So the most recent study is 2008 over here, and the earliest study is 1997. So we can see if there is some sort of temporal trend of improvement in treatment, and there is clearly not any temporal trend in improvement. So what about DOACs? How have DOACs influenced our management. Here's an overview of the DOACs that we have currently. There are 4 DOACs available in the United States, and they are not all the same, and we tend to think of them as being almost the same, but there are important differences. And we have different mechanisms. There are 3 that are the same mechanism. We have the approval date, the half-life in this column here, and the dosing, and when they may be going off patent and becoming generic. One of the things I'd like you to point out, to note on this, is that the half-lives are very similar for all of them, but the dosing is not. So even though all of them have half-lives that are somewhere on the order of 7 to 12 hours, some of them are dosed twice a day and some are dosed once a day. And that may affect some of the results that we're going to be looking at later on. So how has the use of DOACs changed our management? Has it improved? Well, the answer is kind of. This is a study from the NCDR Pinnacle Registry on cardiology practices from 2008 to 2014, looking at over 600,000 patients with non-valvular atrial fibrillation and a high CHA DS VASc score. What they looked at was the overall treatment of patients who should have been treated, basically. And what we see is that at the beginning of the study in 2008, just over 50% were being treated. As the study went on and various DOACs were added, we can see the colored bars or portions here show the different DOACs in initiation of the different DOACs. There is a very modest improvement in the treatment rate. What about the higher risk patients? Again, there's another study from the Pinnacle database looking at patients with congestive heart failure. And this study looked at HFpEF versus HFrEF. And this was also based on the NCDR Pinnacle Registry and over 300,000 patients. And what they looked at was the anticoagulation rates in those patients based on whether they had HFrEF or HFpEF, and over time. And what they saw was that there was overall a very poor result. Only 61% of those with HFpEF were being treated with anticoagulation, and 64 in the HFrEF population, even though the HFpEF population had a higher CHA DS VASc score. And this is the graph of that, showing the CHA DS VASc on the x-axis and the percent that were being treated with anticoagulation. You can see the biggest discrepancy between HFpEF and HFrEF is in the lowest CHA DS VASc score. So what are the barriers to treating with anticoagulation? Why are we doing such a poor job? This has actually been studied, and one of the major problems is physicians. And when questioned, physicians tend to overestimate the bleeding risk of anticoagulation, often by as much as tenfold compared to the actual data. They tend to underestimate the benefit of anticoagulation in terms of stroke reduction. But to me, one of the most interesting problems is that they would feel responsible if they prescribe an anticoagulant and the patient has a hemorrhage. Whereas if the patient has a stroke and they didn't prescribe an anticoagulant, they figure, oh, well, that just happens. So it's partially human psychology that's operating here. Obviously, there are patient factors as well. There's patient preference and also cost. There's no question that the DOACs tend to be more expensive until they become generic. So back to our steps in stroke prevention with atrial fibrillation. We've talked about what is the problem with treating with anticoagulation, that we're not doing it enough. And the next step is to assess the stroke and bleeding risk. And obviously that is a major problem that we as physicians have. So what data do we have about the stroke and bleeding risk? The way we assess the stroke risk is by a score called the CHA VASc. And so I always like to go back to the history. Where did CHA VASc come from? It was a refinement of the so-called Birmingham score, and it was validated on the Euro Heart Survey for atrial fibrillation. And it was based on just over 7,000 subjects, of whom over 1,500 were not on warfarin. So I didn't realize that this was a relatively small population, and a significant number of them were not on warfarin. They excluded patients with mitral stenosis or valve surgery, and their outcome was thromboembolic strokes per year. There was variable aspirin use, but they had the same results with or without the correction for the aspirin patients. And this is their raw data of the stroke risk per year as a function of this CHA VASc, this new score that they developed. Well, this was a fairly small cohort that they looked at, but fortunately it's been validated by a much larger cohort since then. So this is a validation cohort with over 60,000 subjects with atrial fibrillation, not on warfarin in this case, no mitral stenosis or valve surgery. They were followed from the diagnosis of atrial fibrillation to either an event or prescription of anticoagulation. So you might say, well, why are we even following patients who have atrial fibrillation and not on a warfarin? What they did is they just said, well, they were diagnosed, how long was it until they were on a warfarin? And that was their observation period in many cases. Just they got prescribed what happened before that. And what the nice thing is that if we compare the original data in blue and this much larger data set, it tracks pretty well. The annualized overall rate of stroke was 2.99%. What about the assessment of bleeding risk? That's based on a score called the HAS-BLED. And going back to the original validation of HAS-BLED, it was a simplified risk model to replace a more complicated risk model. It was based on about 3,000 subjects, again in the Euro Heart study on AFib. Only 65% were on warfarin. 13% were on antiplatelet therapy. 24% were only on antiplatelet therapy, and 10% were on no therapy at all. What was interesting is that although they got a good correlation and good prediction based on the model, their prediction was worse, but was best for those on no therapy or antiplatelet therapy alone, and was worst with patients on warfarin. So they had a poor correlation there. So what about with DOACs? We have the original data that was done by the validation by the companies, but what about post-marketing studies? There's a very large study called ARISTOPHANES, which over 400,000 subjects retrospectively analyzed based on DOAC use. This was from Medicare, Medicaid, and commercial databases during 2013 to 2015. And they created 6 matched cohorts for each type of DOAC. They matched patients in this cohort who are on warfarin based on a propensity score. And they compared to warfarin, and then they also compared to DOAC. So that was the reason they had 6 different cohorts. And the numbers of the cohorts for warfarin comparison ranged from about almost 37,000 to 125,000 pairs, while for the DOAC comparisons, the cohorts ranged from about 37,000 to 107,000 pairs. So these were very large matched cohorts based on propensity scores. All of the DOACs had significantly lower risk for stroke than warfarin, although there were differences between the DOACs. Apixaban and dabigatran had lower major bleeding risk than warfarin, but rivaroxaban had higher major bleeding risk. So here is one of the tables from the ARISTOPHANES study. What we have here is, this is apixaban versus warfarin, stroke risk, near major bleeding. Dabigatran versus warfarin, same parameters. Rivaroxaban versus warfarin, same parameters. I'd like to highlight a few areas. First of all, for apixaban versus warfarin, we can see that the stroke risk is significantly lower than for warfarin. We're talking about 40%, 60%, rather than 100%. For dabigatran, it's about mostly the same, although the overall stroke risk is slightly lower. And for rivaroxaban, it's a little bit better, sort of in between. This is kind of Goldilocks and the three bears. I'd like to highlight the bleeding risk with apixaban compared to warfarin, where we have 60% down to 56% compared to 100% for warfarin. So about a 40 to 50% reduction in bleeding risk with apixaban compared to warfarin. Now, I'd also like to point out that for all of the DOACs, the most feared bleeding problem, which is intracranial hemorrhage, was lower with all of them, ranging from 43% to 63% of the bleeding risk with warfarin. Another real-world comparison of DOACs, which has an interesting little twist in it, was from Taiwan and was published just last year. This was a retrospective study from 2012 to 2017 with almost 90,000 subjects with non-valvular atrial fibrillation, with fairly large groups in each group. Again, they did a propensity matching for patients with warfarin. The particular part that I thought was interesting for this study was that they looked at low dose treatment, where patients were on low doses because of either creatinine or body weight or elderly age, and compared how those patients did with warfarin. And this is the results for the different DOACs for ischemic stroke, intracranial hemorrhage, major GI bleed, and all major bleeding. What I'd like to point out is for the intracranial hemorrhage, they all had dramatically lower risk of intracranial hemorrhage than warfarin, and same thing for major bleeding. Recall that one of the major reasons that physicians are not prescribing anticoagulation is fear of bleeding. So I think this should impact how we look at this. One of the very interesting twists on this study was they also looked at patients who were on inappropriately low dose DOACs. What they meant was patients who should have been on full dose DOACs, but were inappropriately dosed at a low dose, meaning that they weren't elderly, elevated creatinine, or low body weight. And what they found was those patients also had lower bleeding risk or intracranial hemorrhage and all bleeding, although their ischemic stroke rate was almost the same or slightly better than if they had been on warfarin. So perhaps these patients that we're very, very worried about, who are frail, and we're saying, oh, I don't want to start anticoagulation on this patient, it would be, rather than not starting anticoagulation at all, it would be better to start a low-dose DOAC, even though that's not according to our current guidelines. There's increasing interest in what happens to those patients on low-dose DOACs. And at the recent AHA scientific sessions in November, there were two presentations that I'd like to highlight about that. One was from newly initiated oral anticoagulation for non-valvular atrial fibrillation in Sweden from 2011 to 2017. Over 64,000 patients, 15,000 with low-dose DOAC, and they did a propensity matching with those on warfarin. And what they found that all event rates were lower in the low-dose DOAC cohort than with the warfarin cohort. So these are the data that they had for stroke, major bleeding, intracranial hemorrhage, and GI bleeding. So this is all low-dose DOACs that are appropriately dosed. Another study came from France and again had an interesting twist. This one also looked at incident non-valvular atrial fibrillation with a 2-year follow-up, 118,000 patient studies, subjects in study. They were looking primarily at low-dose rivaroxaban. There were 12,000 that were studied who were started on low-dose rivaroxaban, and they matched them with the same number of patients with warfarin based on propensity matching. And as expected, overall risk increased with CHA DSVASc. That's not shown here. But there was no significant stroke or embolism difference between rivaroxaban and warfarin, and that's shown in the first graph up here. What was intriguing was that the bleeding risk was lower for patients on low-dose rivaroxaban than with warfarin, and that benefit was higher at higher HAS-BLED scores. So with a HAS-BLED of 0 to 1, there really was no benefit. By the time you got to a HAS-BLED of 4 or higher, then the patients on low-dose rivaroxaban had less bleeding than if they were on warfarin. So the higher the risk, the greater the benefit with using a low-dose DOAC. So let's shift gears a little bit. Now that we've realized that the risk of bleeding is lower with patients who are on a DOAC, maybe we should change our risk-benefits ratio when we're making a decision about starting somebody on oral anticoagulation. In particular, we normally start thinking about anticoagulation at a CHA DSVASc of 2. Maybe we should think about 1. Well, why is it that we choose that threshold of 2? In general, an event rate of 1% per year is considered the threshold for considering anticoagulation. And the reason for that is shown in this little table, which shows the original data on the CHA DSVASc event rates versus the HAS-BLED for different levels in terms of bleeds. And so we're trying to balance a CHADS to the event rate of around 1% versus a bleeding rate of around 1%. And we're saying that's the balance. But if the bleeding rate is quite a bit lower, maybe our threshold for treatment should be lower as well. So in the original validation, then the hazard between 0 and CHA DSVASc of 0 and 1 was almost 2 times higher risk in CHA DSVASc 1 than 0. So it's not a trivial jump with the absolute risk of 0.8%. There are multiple studies showing that the actual risk for CHA DSVASc 1 ranges between 0.5% to up to 2.9% in some studies, depending on the population. So there's been a change in thinking about CHA DSVASc 1. In the 2014 AHA guidelines, recommended no treatment for CHA DSVASc 1 or aspirin. The 2016 ESC guidelines recommended that you should consider full anticoagulation with an oral anticoagulant for CHA VASc 1 in men and CHA VASc 2 in women. The recent update from 2019 from the ACC now is the same as the ESC guidelines, recommending that you consider anticoagulation for CHA VASc 1. But given the lower bleeding risk with DOACs, I expect that there will be additional trials and stronger recommendations. So how big is that population of CHA VASc 1? Well, to give some idea, there's one study that looked at various risk scores, and the moderate risk score based on CHA VASc, this is the population that is CHA VASc 1, was almost 11% of their overall atrial fibrillation population. So that's 11% of all of our patients who maybe should be treated that are not being treated now. What about trying to get a little bit more of a granular look at that risk at that lowest level? This study was actually comparing different risk scores for atrial fibrillation, the CHA VASc versus CHADS versus another newer score called Atria. And the Atria score is a little bit more, uses the same factors as the CHA VASc, but without vascular disease, adding proteinuria and the GFR. There's a stronger weighting for age with more granular levels. And the overall result is that it's much more granular at low risk. And so we can see that we have many different levels at the lowest level. So if we're interested in perhaps expanding who should be treated with anticoagulants, this may be of interest. Again, we're going to switch gears. What is non-valvular atrial fibrillation? We all know that we're supposed to be treating non-valvular atrial fibrillation. If it's atrial fibrillation that's valvular, then that's different. Well, what is that? So, rheumatic mitral stenosis confers a 3 to 4 times increased stroke risk compared to all other types of atrial fibrillation. So that's clearly in a different category and has been identified for decades. Originally, the distinction, therefore, was between non-rheumatic and rheumatic atrial fibrillation. Rheumatic meaning due to mitral stenosis. In the 1996 guidelines, this was shortened to non-valvular atrial fibrillation, although in the guidelines, they never defined what that was. What they meant was non-rheumatic, not associated with mitral stenosis. But I went through the guidelines, they never defined what that was. They just called it non-valvular. The original RELY trial on dabigatran excluded prosthetic valves or hemodynamically significant valve disease, not just mitral stenosis, any type of valve disease. And that sort of led to the dabigatran having the proviso that you should only use it for non-valvular atrial fibrillation. The 2014 ACC guidelines specify that dabigatran is excluded for patients with prosthetic valve, heart valve, or hemodynamically significant valve disease. Again, promoting this idea this is non-valvular atrial fibrillation. In the 2019 update, they point out that the distinction between non-valvular and valvular atrial fibrillation has confused clinicians. Really? In fact, I think there's a tremendous confusion that in fact it was just rheumatic mitral stenosis that was intended as valvular atrial fibrillation. And so in those same guidelines, they say non-valvular atrial fibrillation is atrial fibrillation in the absence of moderate to severe mitral stenosis or mechanical valve. So that's what they mean. They've now defined what non-valvular atrial fibrillation is. So if you have other types of valve disease or a bioprosthetic valve, that is not that is still non-valvular atrial fibrillation. So what about the different trials on DOACs? This also caused some confusion because there was a variability in what kind of valvular disease they included and didn't include. So here we have the different trials, Rely, Rocket AF, Aristotle, and Gauge AF. Here's the different type of DOAC, whether they included a mechanical prosthesis, bioprosthesis. Obviously none of them included mechanical prostheses, whether they included valvular repair, moderate to severe aortic stenosis, significant valve disease, mild to moderate valve disease. Just to make it a little clearer, here are the no's in those different trials. And there was a very significant difference between the trials. Another question of interest is the burden of atrial fibrillation. How much atrial fibrillation does a patient actually have? So we'll have a brief history of atrial fibrillation burden. In 1994, our own Rick Page, previous head of cardiology, documented that episodes of paroxysmal atrial fibrillation are frequently asymptomatic. In 2000, there was the SPAF study, which documented that there was no difference in that study between paroxysmal and permanent AFib in terms of the risk of stroke. In 2015, then there was a study showing that there was a difference between different patterns, that paroxysmal had a 2% risk, persistent 3%, and permanent a 4% risk of stroke. A number of studies have looked at atrial high rate events, which are device detection of atrial activity as a surrogate for atrial fibrillation. And the MOST study showed that that anybody who had more than 5 minutes of what looked like atrial fibrillation had up to a 2.8 per times increased risk of stroke. There was a study in 2009 showing that there was an interaction between these high atrial events and the burden of those and the CHA DS risk score in terms of risk, stroke risk. In the ASSERT trial in 2012, then they found that if there was over 18 hours of high rate events, there was a hazard ratio of 4 times higher risk of stroke. The KP rhythm study in 2018 showed that the highest tertile of atrial fibrillation burden with paroxysmal atrial fibrillation had a hazard ratio of 3.3 times more stroke risk than the lowest tertile. So the conclusions are that atrial fibrillation matters, the thresholds still need to be defined, risk factors probably interact with these, and the method of monitoring still needs to be defined. These are the studies that I'm citing. So now, back to the first part of our paradigm. Do you have atrial fibrillation? One of the problems is trying to define whether people have atrial fibrillation before they have their stroke, or before they show up with atrial fibrillation. And the problem is that up to 30% of new strokes or TI are thought to be cardioembolic based on our current ways of diagnoses. About 40% after we've been evaluated are felt to be cryptogenic at the time of discharge. And some of those may be due to occult atrial fibrillation still. And it's useful to characterize these patients into those who have known atrial fibrillation prior to being admitted with their stroke, which we already know about. Those who were undiagnosed prior to their stroke, and we'd like to try to diagnose them before they have their stroke, but they're diagnosed at the time of hospitalization. And then patients who may have paroxysmal atrial fibrillation that caused their stroke, but they were undiagnosed before, at the time of their hospitalization, and maybe we have an opportunity to diagnose them afterwards. The EMBRACE trial looked at cryptogenic strokes, so the patients who were undiagnosed at the time of discharge, and used 30-day recorders versus a 24-hour Holter and had a yield of 16% versus 3%. Now, I'm summarizing a very large and rich literature with just a couple of trials here, with just some key ones. The Crystal AF used an implantable loop recorder for up to 3 years and found significantly more atrial fibrillation. And this is their key illustration from that trial. We have the time on the x-axis from 0 to 36 months, the control diagnosis of atrial fibrillation versus with the implantable loop recorder, where they got up to 30% diagnosis of atrial fibrillation after 3 years. So this is, again, a very rich literature, but there are some questions of how important that is. And maybe we don't need to look for atrial fibrillation after stroke at all. Why don't we just start them all on DOAC? Well, that actually has been tried. And that was the Navigate ESUS trial, which they attempted to reduce stroke risk in those patients with cryptogenic stroke using rivaroxaban versus aspirin. They had 7,000 subjects, and they were followed for 11 months. The ischemic stroke occurred at an annualized rate of 4.7%, which is pretty high. The trial was stopped early due to a lack of benefit with regard to ischemic stroke, and that's shown in the first graph right here. There was no benefit for being on rivaroxaban in that trial. And also they had a hazard ratio, of bleeding with rivaroxaban that was 2.7 times higher than aspirin. And that was the reason the trial was stopped, because they had increased bleeding. And that's shown here. Now recall that rivaroxaban has the same half-life as apixaban, but it's dosed once a day. And does that mean that it's dosed too high in order to get the stroke risk lower, and that therefore there's more bleeding risk? I'm not sure. It may be that if they used a different DOAC, they wouldn't have had as much bleeding risk, but there's no getting around that they didn't have any benefit. So maybe it's not worth looking at. So what is the relationship between atrial fibrillation diagnosed at the time of stroke versus other situations? It may be very different. So this was a study looking at 23,000 patients with acute ischemic stroke, and they classified them as having stroke prior to they had having atrial fibrillation prior to the stroke, and that was known. Atrial fibrillation that was diagnosed at the time of the stroke, and atrial fibrillation that was found after the stroke. I'm sorry. The third group was patients who did not have atrial fibrillation, called normal sinus rhythm. And what they found was this was the incidence of stroke after their initial hospitalization for those patients who had known atrial fibrillation prior to the hospitalization. For the patients who were diagnosed as atrial fibrillation at the time of their hospitalization, this was the stroke risk, which turned out not to be significantly different from those who did not have atrial fibrillation. So their conclusion was that if you diagnose atrial fibrillation at the time of a stroke, it may be a different situation, a different neurohormonal pathway, that there's activation and sort of incidental atrial fibrillation and not as high risk. And obviously this is hypothesis generating, but not conclusive, but it makes it clear that this is much more complicated than we thought it was. What about trying to find patients before they're diagnosed? Primary screening for atrial fibrillation was adopted by the ESC atrial fibrillation guidelines in 2016 based on variable reads in different populations using different methods. There's 2 weeks of intermittent ECG in 75-year-olds yielding 3% with atrial fibrillation. Pulse palpation ECG yielded 1.54% of new AF in older adults aged 64 years or more. This is biased towards persistent or permanent AFib because this is intermittent, just one-time examination. The current guidelines from the ESC recommends opportunistic screening for those greater than 65 years of age, and has a cost effectiveness analysis of about $3,000 per quality adjusted life year if we're using opportunistic screening. What about if we were to enrich the pool rather than just studying everybody who's over 65? What if we use some sort of risk factor analysis? I studied this with, in a paper we published in 2018, where we did a simulation using the ARIC database and to try to select a subgroup that was at higher risk of atrial fibrillation. And we compared this to using age alone. And we thresholded all of the different risk models, including the one that we had developed, to say that we were going to screen the same number of patients. So the cost is going to be the same. And what the results are shown in this table. So if we use 65 as the cutoff, the ESC guidelines, we would only find 71 of the subjects who subsequently developed atrial fibrillation, or 61%. Several of the risk models found a significantly higher number of the patients who subsequently developed atrial fibrillation. And a point is that these other risk models that performed well required other expensive tests to be implemented, either doing an ECG and interpreting the ECG or some other types of tests. Whereas the model we developed was literally only history. You could talk to somebody on the phone and get all of the factors and still use that as a screening tool. What about newer devices? For like the iWatch, for all of them, there are questions about false positives and cost. The algorithms are proprietary. And strangely, the FDA does not have a minimum accuracy requirement for approval. They just have to, you just report how you performed on a test, but there's no threshold for approval. Many of the devices provide no data on accuracy or very limited data on accuracy. The accuracy results are usually with a proprietary data set, which you can't validate with another algorithm. And they use different methodologies in testing, sometimes using a very enriched data set where they say, we tested on patients who already had a known atrial fibrillation, which is obviously kind of enriching the pool. And so the question is this an appropriate technology? The answer is, I think it probably is, but not in this form. Having an overall multi-use device is probably not what you should have. You should probably have something that is purpose-built for this application, and therefore probably less expensive, more validated, less proprietary. So the algorithms that are used are not all alike. And we tend to think, oh, it's FDA approved, and so therefore it's okay. And as I pointed out, there's no particular criterion. And I developed an algorithm and I decided to compare it in an open way that was non-proprietary, using a non-proprietary database, to other algorithms that were proprietary because they were patented that I could compare to. And the specificity depends upon the threshold. So if you just pick up the threshold, then it's kind of hard to understand what that means. So you need to make sure that they're all at the same threshold in some way. And this was a crossover validation of 4 algorithms, which with the thresholds all set to have exactly the same sensitivity. So that's the way I leveled the playing field. Each record that was analyzed was 10 hours in length, And there's also a problem that the accuracy depends upon how big a segment of are you analyzing. And so I tried different segments, and what I'll show you is the one that makes the other algorithms look best. So I'm trying to cherry pick the one that makes them look the best. False positives are a major problem in screening, because if you have false positives, that means you have to have cost of having a technician, somebody looking at this in detail and understanding this. And so that was the focus of this study. So here are the results. This is the algorithm I developed. This is a Medtronic algorithm that they patented. This is an algorithm that was developed by a doctor who is now suing Apple because he says that their Apple Watch atrial fibrillation algorithm stole his algorithm. So maybe I'm not sure if it's exactly this algorithm or something else that he thinks that they stole. And the last one is an algorithm developed by Gus Barty, who many in the new know. And what we see is that the false positives for my algorithm were better than these others, which means that the cost would be less if this were to be implemented in a screening system. So at the beginning of this talk, I mentioned the title is Gaps in Stroke Prevention and Atrial Fibrillation. And perhaps you thought that it was something like this, where there was a couple of potholes in the road, but it's not that bad. We can fix those. I hope I convinced you that it's more like this. We've got a major problem that we need major repairs that are necessary in our system. And if we start looking at our different paradigm that's part of the paradigm we started out with, then I think that what we're going to see is more treatment of frail, more treatment of valvular heart disease, probably treatment of CHA DS VASc, using atrial fibrillation burden to assess risk, start looking at primary screening for atrial fibrillation. As to screening after cryptogenic stroke, I'm not as sure about that. So what can we look for in stroke prevention and atrial fibrillation? As a wise person once said, predictions are difficult, especially about the future. With that caveat, I'll try to make some predictions. I think it's pretty easy to say that DOACs will replace warfarin for stroke prevention and atrial fibrillation. We will decrease the threshold for recommending DOACs to CHA DS VASc 1 for men. We'll have more liberal recommendation for treatment of frail and elderly. We'll have better bleeding risk assessment appropriate for the DOACs. We'll start using the atrial fibrillation burden as in risk assessment, especially for CHA DS VASc 1. We'll be making more liberal use in valvular heart disease. There will be targeted screening for asymptomatic atrial fibrillation based on risk. Lower cost wearables will be used for screening high-risk patients. I don't think for general population, like in some studies that are being done now. Undertreatment will continue to be a problem for sure. Stay tuned. I think that there will be generic DOACs coming along. We didn't talk about biomarkers and fibrosis for risk stratification, another area of interest. More utilization of low dose or split dose regimens for DOACs, and possible replacement of CHA DS VASc score by the Atria score. I'd like to thank a number of people who have collaborated over the years, Dr. Rowe and Dr. Roth here in the Division of Cardiology, Drs. Muqdad and Murphy at the Institute for Health Metrics and Evaluation, and UCLA, Dr. Swerdlow and Dr.